Patients sometimes feel neglected, but it's actually more like nobody wants to treat something they're not comfortable with. And it's a lack of education and exposure to it, more so than I don't care about this, you know. A large group of Meniere's patients are migraineurs, and in some cases, the attacks are almost indistinguishable. And there's other cases where patients fulfill criteria for both disorders as we currently recognize them. We're not going anywhere with beta histine and diazide or steroid injections. Let's try to treat the headaches. And I would treat the headaches, and their Meniere's symptoms would go away, even though they didn't fulfill criteria for vestibular migraine.
Welcome to Meniere's Without the Spin. If you follow my writing on Substack, you'll know that in recent years there's been quite a bit of research into Meniere's trying to understand the mechanisms that lead to our symptoms and looking into what's really going on in the inner ear. All of this is great and completely necessary, but it's a long way from the experience of the poor patient who visits their doctor with a collection of awful, debilitating symptoms and just needs support and help. So it was wonderful to sit down with Dr. Habib Rizk, who has worked for many years to try to bridge that gap between the world of research and the patient experience. Dr. Rizk is both a clinician and a researcher. He's Associate Professor of Otolaryngology and Head and Neck Surgery at the Medical University of South Carolina, and also Director of the Vestibular Clinic there. He's a member of the Barony Society that defines the international diagnostic criteria for vestibular disorders like Meniere's and vestibular migraine. And he's just finished his stint as president of the Vestibular Disorders Association, VeDA. He presents frequently at meetings and conferences on disorders like Meniere's and vestibular migraine, focusing particularly on improving the clinical care for patients. We spent quite some time discussing Meniere's disease and vestibular migraine, the overlap between them, and the possibility of shared treatment approaches to them. We talked about approaches for testing Meniere's and vestibular migraine. We also dug into the difficulties of testing treatments for these conditions and how recent work on subtypes for Meniere's disease might well help this sort of testing in the future. And we discussed the improving awareness of doctors when it comes to vestibular conditions, which should hopefully improve the experience for patients. So I give you Dr. Habib Rizk. Would I be right in saying one of your focuses has been to try and bridge the gap between the research in vestibular disorders and the patient sort of experience? How do you think that's changed during your career, and do you think there's still improvements to be made?
In vestibular disorders in general, yes, of course, there's a lot of, there's not enough interventional research available, quite honestly. I mean, a lot of the research now is with vestibular migraine, for example, is geared toward understanding it better. And we have a host of medications that we've used for a long time for other types of migraine. There's not like a vestibular migraine specific drug. We still don't understand the pathophysiology of vestibular migraine. And that also translates to Meniere's, where the opposite is happening. We have a lot of interventional studies geared toward the vertigo, but not the sound, the other otologic symptoms, the tinnitus, the hyperacusis, the hearing loss, which at the end of the day, a patient with Meniere's suffers from all of those. And yes, it's true, they say I could sacrifice my hearing to get rid of the vertigo, but when I've asked patients who have had remission of their vertigo, what is their number one complaint? Consistently, it came back as hyperacusis or, the constant fullness and feeling, underwater.
Yeah.
So there's also that other host of Meniere's patients who have other complaints that we're not necessarily focusing on in the immediate clinical setting.
Okay, yeah, that's interesting. I think that's absolutely something that's come to dominate my life in the last few years, is the hearing issues, more so than the vertigo. I mean, the vertigo still comes, but it's self-contained. But I'm a musician, and I've actually suffered a lot of diplacusis, hearing completely the wrong pitch of tones, and that seems to be almost a completely unreported but quite common symptom of Meniere's, which I mean, I don't remember reading anything about it until I started experiencing it myself and digging a little bit. Is that
It
something
is a
you've?
phenomenon that we recognize called recruitment in the cochlea, where the wrong population of hair cells is trying to bridge the dead zones, and that creates this sound sensitivity, loudness, comfortable loudness threshold goes down, and in some cases, the placusis.
What I found really interesting about that is that I initially thought it would be permanent, but mine seems to have come and gone and come and gone again. It looks like it's also potentially a mechanical issue or
The
some
placusis, you mean?
the diplacusis. Yeah,
Well, I mean, it's kind of like all of the symptoms of Meniere's before permanent damage settles in. There is a fluctuation in the amount of inflammation and swelling that occurs that can affect the functioning of the hair cells. The question is, I mean, what we know now about Meniere's that we didn't really recognize a decade ago, or we're not convinced of a decade ago, is that there are many types of Meniere's disease, and it's not one disease, which makes it hard to set clinical trials and that are geared toward a heterogeneous population. And when you do a clinical trial and you want results, you want the purest form of a patient population. And with Meniere's disease, right now, it's almost impossible to select and stratify the patients. It's not impossible, but it's logistically impossible. It's not medically impossible.
yeah, that's actually something I wanted to come on to talk about a bit later. But since you've brought it up, do you think? I mean, at the moment, it doesn't seem to be happening in trials of treatments. Do you think that's going to start happening to try to stratify, to do blood tests for different types of subtypes of Meniere's?
I mean, the work of Dr. Lopez Escamas gives us an idea of how to stratify patients based on cytokine profiles. And at the end of the day, clinical trials run on money, and money is not always available, and you have to make choices. And yes, whenever we're discussing new trials, this is something that is always brought up nowadays. Uh, but we haven't, I think it's going to start happening, but you need to dedicate the funding for it. And
Right.
the current funding climate, sometimes sacrifices are made to streamline a clinical trial, which are not necessarily the best choices if you are in a utopic, context.
Yeah. Do you think that this might be a key reason why so many treatment trials end up as a bit of a washout?
Yes, 100%. I mean, like I did a clinical trial in one center, my center, like my clinic, using venlafaxine. I did a randomized placebo-controlled clinical trial. And statistically, I didn't get results that are convincing, but I have patients 5 years out who are still on the drug and refuse to come off of it because the minute we put them on it, their symptoms settle. So there's something to be said about clinical evidence outside of a level A randomized clinical trial that is still valuable for the patient in a clinical setting. I mean, medicine is empiric at the end of the day. And yes, evidence-based medicine is important, but also looking at the patient in front of you and what they're responding to and using the best tools you have at your disposal. But to answer your question, yes, we have issues with the design of clinical trials for Meniere's disease because of how difficult and how heterogeneous, how difficult it is to stratify the patients with easy
Yeah.
tools.
Is that I see. I think I saw somewhere that you've suggested that maybe this STAR D
Yeah.
approach that has been trialed for treatment-resistant depression might be a way to go. Can you say a bit more about that? Because that looked interesting.
So when we did our study and we saw that we had a large placebo effect, we thought about what could have made the study better. And one of them was, first of all, an increase in the duration and the length of the study and recruiting more patients. But also, when you start going into lengthier trials with a disease like Meniere's disease, your compliance for patients goes down. And patients are not willing to go to suffer 12 months of vertigo, debilitating vertigo and hearing loss, if there's no guarantee that they're going to do better. Um, so the STAR-D design basically hand selects available treatments that the patient approves of. For example, you give them a list of diuretic, beta histine, a new drug on the market, steroid injections, and you set it up in a randomized way how they will evolve into each treatment category as they're advancing through each category. So if they succeed, they continue. If they fail, treatment A and treatment B, C, D are on the choices they have made already, like they are approving the risk of treatment B, C, D, then we randomize them to B, C, or D. Obviously, this is an ideal type of trial in this setting, but that requires a lot of funds. And in a
Yeah.
disease as rare as Meniere's disease, from a recruitment standpoint, it's going to require a lot of funding, a lot of patients, multiple centers involved in it. And that's why it's difficult to implement. But that's one of the ideas of how to think about designing new clinical trials in the new era of Meniere's disease understanding.
Yeah, that's interesting. So would the outcome of that then be a kind of pathway that would suggest, okay, try this, and if it doesn't work, try that, and if not, try that?
Yes. Yes. And
Okay.
actually, that's how we behave in clinic. I mean, this is one of those disorders where I think the research has to mimic what we do in clinic. This is the algorithm we use in clinic. We use things that were never really tested, diazide and beta histine, like tested in with high level of evidence, and yet they work on a subset of patients. So if we identify finally a specific pathway that works for a specific group of patients, that we can go back and analyze what is particular about this group of patients. But it
Okay.
also allows the patient to stay longer in clinical trials because
Right.
they're going to be cycling in and out of an active treatment rather than in and out of a placebo versus treatment. And the idea that they're going to get a sugar pill for 6 months is very few patients would sign up for it.
Yeah.
And and yet they did for a lot of the studies we did, they accept because this is how committed they are. But at some point there has to be some guarantee that they're going to receive some sort of active treatment to try to settle down their disease.
Okay. Okay. I get it. Yeah. No, that's really interesting. So, how did you end up getting interested in vestibular disorders in the first place? What was your route to
Yeah,
that?
my fellowship, I did 5 years of residency in ENT, and then I did an otology fellowship with Dr. Michael Teixido. And this is where I got introduced to vestibular disorders. And then I followed up with a neurootology fellowship at the Medical University of South Carolina, where I am right now, and decided that's the focus that I'm most interested in. It was, and basically my experience speaks to how the state of vestibular disorders in medicine was about 12 years ago when I finished residency in 2012, 14 years ago. We didn't get exposed to it in residency. It wasn't something on our radar. And when I started seeing vestibular disorders in ENT, it was kind of an oddity that we are taking ownership of those patients. But now it's become more streamlined. Like there's many colleagues of mine across the country who are ENT and who are interested in vestibular disorders. We have more residents graduating with a better understanding of how to treat those patients. So also the landscape of education in vestibular disorders has shifted in the US in the past decade.
Okay. So you see things improving.
I see things are better, and it's still underrepresented. And the difficulty with vestibular disorders is that, kind of like in the patient population, there's many entry points to the healthcare system, and you cannot control every specialty's educational path. But in ENT, there's a lot of strides to improve the education of the general otolaryngologist and their exposure to vestibular disorders. The effort is being seen at the level of the American Academy of Otolaryngology that provides a lot of educational resources, but also in every residency program. Like there's a big curriculum that we wrote for vestibular disorders over the past few years. So things are getting better on our side of
Okay.
the equation.
Yeah, that's good to hear because it is something that comes up an awful lot in the support forums and groups and things. People feeling that their vestibular condition is not well understood or sometimes not taken seriously. I think it's good to hear that that's improving, and I guess and it's an education problem.
Yeah, I mean, patients sometimes feel neglected, but it's actually more like, you know, nobody wants to treat something they're not comfortable with. And it's a lack of education and exposure to it, more so than I don't care about this.
Yeah,
If you're not comfortable treating it, you won't treat it appropriately. And vestibular clinics are few and far in between, and they are difficult to get in with. And so that's where patients kind of fall through the cracks. But this is also where support groups are important because they can guide the patient to the right path.
right.
We just did uh, we got a study published with the Vestibular Disorders Association looking at the VeDA registry and looking at access to healthcare of vestibular patients. And, it's kind of disconcerting that the average patient has to see about 15 providers before getting to a diagnosis. That's because they're
Wow.
lumped between family physician, neurology, emergency room, ENT, general ENT, neurotology, until they get to the right path. But this is data based on the experience of patients who went through the system in the past several years. And I think if we resurvey in a few years, that could change.
Yeah, that's interesting. I mean, I should say for those people who will be watching this or listening to this that you are currently the president of VeDA, right?
I just finished my
Are
term
you finished? Okay, you have
on
been.
the board. Yeah.
Yeah. So how do you, I mean, you've already sort of touched on it, but how do you feel that organizations like VeDA fit into the patient experience?
I think VeDA is an under-recognized resource for vestibular patients. It's a nonprofit. It provides a lot of resources, online support forums, toolkits to help them even express their symptoms to their physicians. A lot of times patients come to the physician with problems, but they don't know how to express the symptom. It's a
Mm.
very difficult symptom to talk about, not difficult emotionally, difficult to describe.
Yeah.
And education goes a long way when you educate the patient on what are the things that are needed so that the physician helps you get where you need to be, and which makes it easier to navigate the healthcare system, which is challenging, to say the least. So organizations like VeDA are primarily patient education resources. They are, volunteer organization for the most part with a small skeleton staff, and they rely on donations. So it's not like a money-making organization. Just it started as a support group in Oregon in the 1980s, and it's been continuously working since
Okay.
then.
Yeah. You're actually making me feel slightly guilty now because I volunteered a while back because I have an IT background to help out with some database management stuff at VeDA, and I actually haven't managed to find the time to do it. So I need to do that. But so yeah, you've touched on things that VeDA is obviously doing very well. Are there areas where you feel it could improve or things that could be done better?
Um, we, since I joined the board, and now Dr. Amir Karadman from Johns Hopkins is the current president. We're working on improving the interface of VeDA with the medical profession. Um, VeDA has, for a long period of time, been mostly the relationship was mostly with physical therapists, but the actual mission of VeDA is to provide education for patients, but also to all healthcare professionals dedicated to vestibular disorders. And in the vein of this collaboration, we created a lot of joint collaborations with the AMA, Educational Hub. We're working on developing educational resources for the general medical community.
Okay.
We also developed a grant with the American Neurotology Society to reinforce research in vestibular disorders through the neuro-otologists like me, like in the ENT community, which will, I mean, if you provide more funding, more seed funding for pilot projects, you can, this is how you start. This is the building block for more research down the line. So this is the new aspect of what we're currently trying to develop with VeDA, this boosting the medical education component.
Okay, oh, that's interesting. And how does VeDA approach the concepts of science and evidence? Because there's a vast spectrum of potential approaches to treatment that are available, and some of them have more of an evidence base and a grounding in science than some of
Yeah.
the others, I guess.
I mean, VeDA, I cannot speak for VeDA as a whole, but my experience with them since I was on their board is that we try to present patients with everything available and highlight the evidence behind it. There's a group of medical advisors that sometimes review controversial evidence, and we decide not to put something like that to be available because we feel like it's not in the best interest of patients. Or if there is limited evidence, we post it with the disclaimer, this is limited evidence, may not work. But at the end of the day, VeDA is not there to other than a resource for patients and to clarify and to highlight certain pitfalls. Like we cannot say don't go to a chiropractor because sometimes chiropractors can have things or tools that can help certain patients with dizziness, but we highlight the limitations of certain approaches. We cannot say don't go to neurooptometry because, yes, sometimes people can have a binocular vergence disorder, but it's almost never the only cause of their dizziness. So this is the way, the nuance that the medical advisory board of VeDA brings to the table by explaining and making sure that the information that goes out there has been vetted for the most part.
Sorry to interrupt. If this kind of content about Meniere's and vestibular conditions is useful, please consider liking and subscribing. It really, really helps others to find the material. I'll also be writing an in-depth article on this interview over on my Substack, where I will explain some of the less obvious concepts in more detail and also dig much more deeply into the things that we discussed. If you want to support both this channel and the writing on Substack, head over there where you can take a free subscription, or if you feel like it, you can even donate to support the work that I'm trying to do. So you mentioned vestibular migraine at the start, and there seems to be a lot of discussion about the potential overlap, and in some cases, I know there are people out there saying that Meniere's and vestibular migraine might even be exactly the same thing. What's your perspective on that?
I think a subtype of Meniere's disease has a migraine pathogenesis. It's kind of very clear when you see them like the patterns appear in clinic. I do have a group of Meniere's patients who don't have anything to do with migraine. They don't even have any migraine manifestations. But a large group of Meniere's patients are migraineurs. And in some cases, the attacks are almost indistinguishable. And there's other cases where patients fulfill criteria for both disorders as we currently recognize them. And that could change. Maybe in the future, this is going to be a big part of a migraine of the autologic migraine that can present with the Meniere's phenotype. And it's not far-fetched as a theory. I mean, the endophenotype research that Dr. Lopez Escamas published on shows an autoinflammatory group on the cytokine profile. And migraine is an autoinflammatory disorder. So it's not far-fetched at all. Migraine is known to affect the trigeminal pathway, causing sinus pressure and facial pressure and ear pain. And the trigeminal pathway is is the main innervation of the inner ear. So if you're, irritating the branch of V2 going to the sinus, you can very well irritate the auriculotemporal branch that sends branches off to the ear. So the theoretical framework for that is very clear. The key evidence that you need at the basic science level is still missing. And that's part of what research, as I was saying, is focusing on. Trying to identify the pathogenesis of vestibular migraine is going to be interesting in the next few years.
Yes, it does seem to be. You certainly see a lot of people in the forums that seem to have ended up with both diagnoses or seem to have symptoms that overlap
And
from.
even in my patients who don't have an overlap or any migraine manifestations, I treat sometimes a pure Meniere's patient with a migraine preventive drug. The old school migraine preventive drug are not targeted, like the new anti-CGRP, which are recognized to be in the headache pathway. But nortriptyline, venlafaxine, topamax, all of those are sodium channel blockers, so they can affect the endolymph. So, and they have a pleiotropic effect on the brain. So it's very likely that they also work on Meniere's disease, even if there's not a migraine pathology. At least clinically, that's what I recognize at times.
That was actually going to be one of my questions. So can you just say a little bit more about that? That's the reason behind your trial of venlafaxine.
Yes, that started. So the venlafaxine trial came to be because of my clinical experience with patients. I would have patients with Meniere's disease. Some of them would have migraine headaches. And I would say, okay, we're not going anywhere with beta histine and diazide or steroid injections. Let's try to treat the headaches. And I would treat the headaches, and their Meniere's symptoms would go away, even though they didn't fulfill criteria for vestibular migraine. They had Meniere's disease that was, definite. So this is where I said, okay, well, how about if we treat Meniere's patients with, like, can we prove that it actually works? That was the theoretical framework of it. And when I designed the study, I used the placebo effect of 20%. And now we know, based on decades of clinical trials, we published a meta-analysis on it recently, that the placebo effect is much higher, which meant that possibly my study was underpowered. And also we used a starting dose of medication. It's a pilot study. So you know, we didn't try a higher dose of venlafaxine, which probably could have helped. So again, there's ideal clinical trials and there's the reality and the funding at the end of the day, that you need to get a signal to continue building up on it.
Yeah,
Does that
yeah,
answer your question?
yeah. No, that's great. So, is there? Do you now suspect that there's a particular subtype within the different types of Meniere's that venlafaxine may have been effective for?
Yes, I'm not sure. I mean, definitely the one who have migraine, but I'm not sure of the inflammatory signature that I'm pretty certain that eventually we're going to find subtypes that, based on the cytokine inflammatory signature, we can hand select which drug needs to be trialed first.
Yeah,
Same with beta histine. I mean, I've had patients who had complete remission the minute you put them on beta histine after failing other stuff. So it's unlikely to be just placebo effect. That's the problem. I mean, but also I read one time a study that placebo effect is part of the treatment, is part of the healthcare equation. We shouldn't discard it, and it's not something necessarily negative. Even drugs for blood pressure medication have a placebo effect in some cases when patients are, relaxed and committed to the treatment. So placebo effect in itself is not a bad thing and could actually amplify the therapeutic effect.
right. Yeah, yeah, absolutely. I wrote an article about the placebo effect a while back, and yeah, I found it really fascinating. Was a good thing. Um, Coming back to the migraines and Meniere's, I saw that you did a trial with VEMP
Yes, we
approaches
looked.
to distinguishing between the two. I found that really interesting. Maybe you can say a little bit more about what that vestibular
Evoke myogenic potential.
myogenic potential. Yeah. Okay. Can you say a bit more about what that is and why there might be a difference between people with migraine and people with Meniere's?
So the VEMP test is one of the tools of the vestibular battery of tests, and it actually tests the utricular and saccular pathways, which are the two small organs inside the vestibular labyrinth. this is where the crystals are housed for people who know what the crystals are. So VEMP tests the integrity of the pathway of the cervical VEMPs test the saccular pathway, and the OVEMP tests the utricular pathway, which means that if you have a deficiency in the pathway, it's not necessarily in the sensor of the ear. It could be somewhere along the pathway that goes to the brainstem, circles through the vestibular nuclei, and goes back to the muscle through the vestibular spinal tract. And we've noticed, well, for many years that a lot of patients would have certain abnormalities on VEM testing, but we didn't know if it is necessarily indicative of a specific pathology. Also, we noticed that patients who have isolated utricular or saccular dysfunction or isolated VEMPs, even if they don't fulfill criteria for vestibular migraine, they sometimes describe a chronic rocking dizziness or a brain fog and a spatial disorientation similar to migraine manifestations. A lot of studies done in zero gravity environments where the only vestibular organs that are working are the utricle and saccule. Also, the astronauts describe a spatial disorientation and a rocking dizziness. So there's something to be about that part of the inner ear and vestibular pathway and those type of symptoms. When we did that study, it was based on our case series. It was before COVID, even, I think, or just around that time. We didn't have the MRI high drops that I currently use more routinely. So we were trying to find a way. Is there any test that could give us an idea or a probability of Meniere's or migraine and which side it is? And we published that study, which is the predictive value of vestibular evoked myogenic potential. And we noticed that OVEMP seems to have a high uh, uh, negative predictive value, meaning if it's absolutely normal, it's less likely to have those disorders. But it's not a diagnostic test. It's the way we think about the collection of current tests that we have is like a how do you call it? You have to, it's like a collection of data, and then you put them in a model, and then you decide if that fits the diagnosis or not. It's not like a gold standard diagnostic test. You do CAT scan and you see a hematoma. But if you have high drops on the MRI, you don't have a low frequency hearing loss, and your OVAMPs are abnormal, and you have episodic recurrent vertigo, you're likely dealing with a migraine type manifestation because you don't have a positive low frequency hearing loss on the audiogram that points you toward Meniere's disease. So this is the way we're going to start thinking about diagnosing those disorders, creating a lot of clues and that lead us to the final diagnosis. And this is where blood testing of cytokines might end up being valuable. Like if you end up streamlining blood tests and we are able to identify a specific inflammatory profile that can get plugged in with the other tools that we have, we might end up having a diagnostic checklist that is objective rather than just subjective like it is now.
Okay, so is the thinking that you the utricle and saccule are basically detecting linear movements, in one case forwards and backwards, and the other case up and down, right?
Saccule is up and down,
Yeah.
utricle is backward and forward. We
And
also
so,
detect gravity and acceleration.
yeah. So then you've got the muscles are kind of automatically almost trying to respond to those movements to correct for the movement in some way. In one case,
Yes.
the eye movement, if it's a left and right movement, and a neck movement if it's an up and down.
Yes.
Yeah, okay. So is the thinking that with Meniere's then there potentially is damage to those organs, whereas with vestibular migraine there wouldn't be, or damage to that
Well, actually,
pathway?
well, both vestibular migraine and Meniere's disease can create a problem in the pathway. With Meniere's disease, the problem is probably at the level of the utricular and saccular sensor, the sensory organ in the inner ear. With vestibular migraine, the theory is that the otolytic pathway that goes to the brainstem is affected, is on high alert with the
Okay.
migraine pathology. And the utricle and sacral involvement explains the drop attacks in Meniere's disease. However, we know that sometimes drop attacks can happen in migraine.
Okay.
So Balo published an old article in the early 2000 about non-otologic drop attacks. And the majority of those patients had migraine disorders. They didn't have vestibular migraine. We didn't have the term then in the early 2000s. But these were not patients with Meniere's disease, and they would have drop attacks, and they had a high probability of having a migraine disorder in the background.
Okay. So I was just trying to see if I could understand from um, a layman's perspective, I guess, how this distinction, how the VEMP test would be distinguishing between the migraine and the
Well, it's not. I mean,
Meniere's.
that's what I was trying to say is that on its own, it's not going to be able to distinguish. But if you plug it in with the list of symptoms and other
Okay.
clues in your history, then you might end up with a diagnostic score. I mean, this is currently how we do clinically. Like I
Mm.
collect information from the patient. A negative audiogram is a clue. A
Right.
negative MRI eye drops that doesn't show significant swelling is a clue. Uh, this is how you build your evidence toward this or that diagnosis.
Okay.
And but unfortunately, we don't have a silver bullet other than the low frequency hearing loss objective metric, other
Mm.
than the low frequency hearing loss to diagnose Meniere's disease right now.
So is that actually a pretty solid?
When it's
Uh,
there, it's confirmatory, yes.
yeah.
But it's
Um,
often not there in the early stages of the disease, or patients have an attack, and by the time they see you, their hearing has recovered.
do we understand why it is the case that we have low frequency hearing loss with Meniere's?
It's the high drops, the swelling that occurs at the basal turn of the cochlea that causes that.
Okay, so that's confirmed because that's something I wanted to ask. There does seem to be some um, discussion or debate about the degree to which high drops is a symptom, a side effect, or a cause of the issues in Meniere's disease. What's your view on that?
I mean, hydrops is unequivocally there in Meniere's disease. The question is it the cause of Meniere's disease? We know now it's like the marker of the problem.
Yeah.
With Meniere's disease, 95% of people will have a vestibular and or cochlear hydrops based on MRI or pathology studies. In other cases, like vestibular migraine, the incidence of a hydrops is much less. So there's something else going on that leads to the symptoms. But yes, hydrops exists in Meniere's disease. Is it the cause? No, but it is part of the manifestation.
Okay. But it is potentially the cause of the low frequency hearing loss, you
Of
feel.
some of the symptoms, yes. It's
Okay.
like what made the symptom happen, potentially the hydrops and the degeneration of that ensues because of the swelling.
Okay. Um, and do you think it accounts for all of the symptoms?
Um, Hard to answer that. For the otologic symptoms, it probably does, in addition to other things like, the irritation of the trigeminal pathway, for example, could explain some of the oral fullness. And I misspoke, the hydrops at the apical turn, not the basal
Yeah.
turn.
Yeah. 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 Okay. Are you of the opinion that the issues are mechanical from these things, or because there seems to be some suggestion that there's more of a biochemical dysregulation
Mhm.
impact on hearing, for example, or rather than a pressure and a mechanical distortion.
Yeah,
Do you
I
think
think
that?
there, again, multiple subtypes. Some of it is homeostasis, ionic dysregulation, inflammatory, autoinflammatory problems that occur. And in some cases, it could be a neuropathy type. Like this is what I the way I would understand how migraine would cause, and this is I'm doing a conjecture here. I don't have basic science data to support that. How could migraine cause the symptoms that we recognize as a Meniere's disease phenotype? It's probably a combination of autoinflammation in the endolymph, as well as some neuropathy of the trigeminal pathway. So it's not going to be, that's where we are failing in clinical trials, is that we're using medications that are targeting a specific pathway, and we're putting patients that we're testing for that don't necessarily follow that pathway.
Right. So it there's a degree to which it could be all of these things or different in different people.
Yes, yes,
Right.
this is yeah, different people, multiple endophenotypes.
Okay. So that then speaks to the treatment needing to be much more tailored and personalized.
Correct. But right now, the state of medicine in that regard is that we can't stratify easily the patients from the get-go in clinic. We can't
Yeah.
stratify them.
Right.
We'll have to try, and most of us have a built-in algorithm that is kind of widely accepted. Low salt diet and diazide. If it fails, beta histine or steroid injections. If it fails, in some cases, you might consider sac, endolymphatic sac surgery. I can't remember the last time I had to do endolymphatic sac surgery. What has changed in recent years is the addition of migraine preventive treatment at that level before moving on to ablative procedures, which I usually strongly recommend against, even gentamicin, if you haven't tried all of the others before.
Right. Yeah. Yes, I was. I mean, when I was originally unilateral, I was scared away from any kind of destructive treatments because of the potential for hearing
Mhm.
loss. And then once I was bilateral, then it wasn't really an option anyway. So
And that's the problem. I mean, 10 to 15% of Meniere's patients may end up having a bilateral disease over the course of their lifetime. Another reason why even if they have been consistently unilateral for most of their lives, we've had cases where we failed everything, and then, patient is almost on disability because of the disorders. And I've had to do a gentamicin or a labyrinthectomy, and then a year later, they presented on the other side after following them for many, many years, and they didn't have it or any inkling of it. So you can have those surprises in a way. And that's why you have to be very careful and counsel the patient appropriately about it.
yeah, yes, okay. Um, do you? What's your view on the role of diet in well, I guess it's Meniere's and vestibular migraine, given that they're so closely related.
I mean, based on the clinical evidence that I have every day in clinic, I have patients who respond to that. It's unequivocal. And I've noticed that in my patients who follow a good low salt and migraine diet and who have remission of their symptoms, they're the least likely to need aggressive interventions over the course of their disease. There's one old study about vestibular migraine that showed that restricting caffeine alone results in 16% it results in improvement in 16% of cases. It's one study, retrospective, an old study, but it's kind of gives you an idea of how potent dietary intervention is.
So when you're talking about dietary intervention, you're talking specifically about sodium and then
Migraine
a
diet.
migraine diet. Okay.
90% of my Meniere's patient, I ask them to follow a migraine diet, which automatically reduces your salt. I strongly recommend against counting sodium to the point where you're less than a 1 gram per day, because that creates problems on its own. Nowadays, the thought process is better to tell the patient to stay in a moderate amount, like
Yeah.
15, like heart healthy, less than 2 grams per day, consistently rather than
avoid
go
the,
very low and
yeah.
then sometimes fluctuate. You have to think of the endolymph and perilymph as like filtrated through the ear, kind of like a kidney functions. And that's why diazide is being used. So a lot of it is related to ionic homeostasis. So, and there's been some studies that showed that restricting salt changes the homeostasis at the level of the endolymph and perilymph.
Okay, yeah. But beyond that, I mean, you sometimes see people talking about restricting sugar or gluten or dairy or various other things.
My theory for those, because I hear it in my clinic, like I stopped sugar or I stopped eating bananas or reduced my potassium rather than my sodium. I think those are patients who potentially could have had a migraine underlying it because those are known migraine triggers, the dairy, the
Okay,
gluten. So
okay, interesting. Yeah. So there is a question because I'm literally, well, I get asked, I guess, pretty much every day. There are questions about this on the forum, so I'm now writing an article about it.
which
Epsilon.
forum is that? That's
Oh,
your blog, your forum?
I'm the admin of two Facebook support
Okay.
groups. There's about 30,000
Wow.
members. One of them I'm the only admin for, and one of them is I was asked to help out,
Mhm.
and then obviously I have my Substack with a couple of thousand subscribers. Um, but almost every day at the moment there are people asking about Epsilon SPI 1005. Do
Yes.
you have a perspective on that? One that you're able to share, or
They just closed the study nationwide. So they just met their recruitment goals, which means it's much earlier than anticipated. So, the unsaid message that probably there is some positive results that they are confident about in the
yeah,
preliminary analysis. But I still, even though we were a big site of the study and we recruited the most patients, I still don't, I'm not privy to the data yet.
no, okay. Because I noticed that
Sounds
the
encouraging. I don't want to, it sounds encouraging.
yeah, I noticed the original phase three trial results finally got published a few days ago.
Mhm.
Now that currently it's the safety long term safety trial, I think. Yeah. Is that
Yes.
right?
But
Okay.
also in real time, like patients taking it consistently
Yeah.
and in a compliant way. And they're looking more at the sound, at the oral fullness, hypercusis, tinnitus, and vertigo is not the primary outcome.
No.
It is an outcome, but it's not the
Yeah.
primary outcome.
Yeah. But the if I'm correct, the theory behind the operation of that is uh, trying to deal with reactive oxygen species and trying to deal with potential damage caused by those things being, I guess, by the ear working too hard when it's got Meniere's and therefore generating too many waste products which are not being cleaned up.
It's an
Um,
antioxidant
yeah,
that's and produces free radicals of oxygen, which are usually the endpoint of any inflammatory, traumatic, anything, any stimulus that is nociceptive to the cell would release that.
right.
Um, so yes, it's kind of they're targeting the last part of the cascade of what inflammation causes to the cells.
Okay. It's one thing that I couldn't understand necessarily whether it was a historical accident or whether there was any reason for it. The fact that then they're not focusing on the vertigo side of things, because I would have thought the damage, if there was damage happening, it would be happening to both the balance organ and the hearing organ. But,
True. I mean, I'm not sure why they decided. I mean, they did publish a few years ago on noise-induced hearing loss and
yeah,
tinnitus with Epsilon, and that created some positive results. So probably this is how they built up on it. I'm not so sure about the inception of the study, why they decided on Epsilon, which we've been trialing from phase one for the past decade. So I'm
Yeah, it
not
certainly
100.
is. It's been tried for a lot of different conditions, I
Yes.
guess, because it's such a powerful antioxidant. So
Yes.
yeah. Well, thank you. I think yeah, we've covered quite a lot of ground, and
I
it's
hope it was
been
helpful.
no, it's been incredibly helpful, and it's a very interesting insight. And I'm I think a lot of the people that might read what I write or watch the video will be very encouraged by your efforts to try to improve the patient experience. I've spoken to a lot of peer researchers or people who've done more of the research down at the lab bench sort of side of things in the past,
Mhm.
and that's all well and good, and people love to hear, okay, we're evolving an understanding of this condition, but actually ultimately they're sitting there in front of a doctor who needs to understand what their situation is. So
Yeah.
thank you
Oh,
very
you're
much. That's been
welcome.
really great.
Yeah, you're
So
welcome.
okay,
Well, have a good day,
yeah,
and
you too.
thanks for
Thank
all
you.
your efforts you're doing. It's not easy to manage a support group, and one of my patients created a support group in our area, and that has been very valuable for our patients with vestibular disorders. So it's a lifeline for a lot of patients who don't have enough family support or friends to understand their condition.
Yeah, no, that's very true. Yeah. Okay. Well, thank you very much. And
Have a good one.
yeah,
Bye-bye.
you too. Bye.